Thank you. Thank you, Chairpersons. And it's a honor at DRS. And I thank my good friend, Dr. Manoj and Dr. Purbi, as well as Dr. Banshi and the whole team of DRS for the invitation and this grand show in the Geo Convention Center where so much of good science is there for last 3 days. My job is to tell you about the type 5 diabetes. And many of you know where from this term came. Long back, we had a concept of MRDM or malnutrition related diabetes mellitus. This type 5 is just a new avatar of MRDM, but they have presumed that chronic malnutrition results in maldevelopment of pancreas, so less insulin secretion. So there is a phenotype in diabetes where the insulin secretion is less, beta cell development is less. Clinically, there are features of malnutrition and they have a profile entirely different to the type 1, type 2, LADA, as well as other type of diabetes. So last IDF at Bangkok was launched a task force which will work on this, a working group which will work on type 5 diabetes, and then the president of IDF, Professor Peter Schwartz, announced a working committee for the Indian team as well as Dr. Meredith Hawkins from the Albert Einstein College of Medicine. I have started working on the concept. So I am just taking you in the lane of history 50 years back where Katak started working on this phenotype, and this article published in 1984 in Lancet, the observation on clinical patterns of diabetes mellitus in India, which first time described the malnutrition can be a etiology for diabetes, because in our area we get a sizable number of patients who have features of malnutrition and at the same time diabetes. So our concept that diabetic or obese with insulin resistance is not always true, and to your surprise, 1/4 of patient of diabetes are either lean or normal BMI with a good amount of insulin resistance. They are not type 1, they are not LADA, they are type, neither they have everything matching to type 2, they are a special class apart. And then Professor Tripathi, Professor Kar, and a group including Professor Keshi Shamal, Professor Siddhar Das, Dr. Alok Kanungo had multiple publications, and in fact, this publication way back in 2014 I did with Professor Das regarding islet B cell response and glucose homeostasis in low body weight type 2 diabetes. So the confusion was between the low body weight and MRDM. A group of people told that malnutrition cannot cause diabetes. So the term which was introduced to the WHO classification was subsequently withdrawn. But class of diabetic who are lean or underweight, they exist. So our study is still continuing. We are in the young diabetes registry where we get the sizable number of patients who have clinical features. I'll tell, and from our registry, our profile, this picture is taken. This is a low body weight type 2 diabetes monogram published by ICP by Professor Siddharth Das. He had taken a group of people, including Dr. Mohan and then Anant Nigam and Shamar Banerjee, and then different centers like Chennai, the Calcutta, Ludhiana, and then Coimbatore. They were all part of this study, and a complete publication was done. And this is the summary of the meeting which took place in 1995 at Cuttack. Here if you'll see who's who of diabetes of the world 30 years back. This is Hotel Akbari, Cuttack, where the international workshop on diabetes peculiar to tropic took place, following which the designation of MRDM PDDM, and FCPD came to the diagnosis of diabetes, and the description, the publication in the Diabetes Care in 1996 was the group supports the WHO classification of NIDDM into obese and non-obese subclasses. Till then, the world believed that the type 2 diabetics are obese. So, in some developing countries, non obese patients constitute the more common category, and a proportion of them have BMI less than 18.5, which was taken at that point of time. And there are many factors that are not well understood in these subjects, with NIDDM and low body weight as well as further research is required to this group, was the conclusion in the Diabetes Care article, and subsequently in 97 classification of ADA, if you see the terms, the MRDM and PDDM came in the heading of malnutrition. So I salute to my mentors, Professor B.B. Tripathi, Professor Siddharth Das, who has worked as head of department of SCB Medical College and taken this project till now. And I'll tell you a few classical features of these patients where the IDF is working, and we started working in 70s, and almost 50 years after, now it has got an international recognition, and you see the global work on this. So the first feature in this lean type 2 or the type 5 or the MRDM, whatever you tell, comes the nutritional aspect, dietary intake and response to treatment. Here there is very clear evidence of malnutrition. These patients didn't take a good diet, and they constitute vast majority of diabetes seen in India and other developing countries, mostly Africa, and internationally they are classified as obese and non-obese. And here these patients, the type 2 diabetics with BMI less than 18.5 had little fat depot, neither poor nor undernourished, but the habitus is lean much prior to onset of the diabetes and continue to be show with prolonged metabolic control. So this is, as I told you, almost 1/4 of the patient of type 2 diabetics were lean in India, and in different cities have presented this profile of nutrition. And I'll show you how they improved. The second feature was clinical profile and complications. And if you see these features, the comorbidities, the hypertension, the coronary artery disease, the peripheral vascular disease, neuropathy, nephropathy, retinopathy, infection like tuberculosis and other infections. The Cuttack studies showed very high incidence of infection. Jaipur study showed good number of cases of tuberculosis, but majority of patients had peripheral neuropathy in most of the centers, which showed a poor control and an increased risk. And then coincidentally, the macrovascular disease like coronary artery disease or peripheral vascular disease were less in this group of patients. And the prevalence of complications there, as I have told, the peripheral neuropathy was there, and then hypertension and coronary artery disease were less common, and none of the subject revealed the presence of peripheral vascular disease or retinopathy. So the dietary practice and advice pre-counseling and post-counseling was different. So the carbohydrates, protein and fat were much less in intake, and they were counseled about the diet with improvement of the nutritional status and improvement of the diabetes as well as the A1C. So if you will see the low body weight, they had a average BMI of 17.4 across 21.7 in normal body weight and 28.3 in obese in our study. And fasting blood glucose was highest in this low body weight group, with vitamin B12 which was also in between the healthy and the normal, and then RBC folate was also very high, and the other parameters like growth hormone was high. So most of the patients were on oral drugs, and insulin was there with few of the patient, but they were well controlled with the oral drug, telling that they're more akin to the type 2 than type 1. So they are the centers which collaborated, and the inflammatory markers like HSCRP, the adiponectin, and nuclear factor kappa B were not raised, showing no inflammation in this group of patients. So the special feature 3 includes the pathogenesis, which showed the insulin resistance in the peripheral bed and beta cell dysfunction and increased hepatic glucose output. So big question came, is the lean built consequent to chronic malnutrition? Do they have poor beta cell reserve for insulin? Is the low insulin level responsible for the persistent hypoglycemia? And does the metabolic profile have any bearing on the morbidity pattern? And interesting data are there ensuring this. So high basal and non-suppressible level of growth hormone is a marker of natural adaptation to chronic nutritionally deprived state, and in this patient it shows a very high value of growth hormone. So that tells that low body weight has always been conceived to the legacy of chronic undernutrition, and you can see here the basal and non-suppressible growth hormone level in this MMDM patients, which are much more higher than the type 1 as well as the type 2. So these are the curves which were taken after different type of diets, the carbohydrate rich, the protein rich and the fat rich diets, and which were interpreted that fasting serum insulin in lean type 2 was higher than the controls, and the glycemic challenge on glycemic challenge, the rise in insulin levels was brisk in control, modest in lean type 2, but poor in the MRDM, and this testified that there was beta cell unresponsiveness to the glucose challenge, but not to the non-glucose substrate, which is a typical pathophysiological characteristic of type 2, telling that this is more nearer to type 2 than type 1. And fourth classical feature was disparity between the circulating level of insulin and C-peptide, and these were low. The circulating level of insulin were low when compared with the classical type 2 in the first state and the fade state. And after years of follow-up, this continued to have substantial level of circulating insulin with preserved beta cell response to glucose more after change in the dietary pattern, which tells that this is correctable. This shows about basal post-glucose and post-glucagon level of plasma insulin and the C-peptide. So beta cell non-responsiveness to glucose was obvious in low body weight as well as classical type 2 diabetes, and this was a common feature in both. The rise following glucagon was very brisk in the classical type 2, not insignificant following of the oral glucose, and response was similar in both groups for the C-peptide as well. The fifth special feature had the hyperactive metabolic state of liver utilizing excess of insulin vis-a-vis producing excess of hepatic glucose in lean type 2 diabetes. In hepatic bed, we had excessive insulin, which was proved with the enzyme glucokinase, which was raised in these patients. So the drugs like antipyrin and lidocaine were used, and they were also showed the increase insulin in the hepatic bed, and then carbohydrate cycle was different in these patients. This shows the glucokinase is high in these low body weight patients, and that was statistically significant, as well as the glucokinase the levels were demonstrated. The special feature 6 tells that the type of dyslipidemia, effect of glycemic starters on the urinary protein excretion, what happens to albuminuria, and further studies on the insulin reserve and beta cell function using homeostatic model, that's the HOMA-IR. So here we can see that the patients had the different levels, the at entry, at the 1 year after and 2 year after. This shows from all the centers that the lipid profiles were different, where the you can see here the triglyceride in the low body weight were very high, and the LDL cholesterol was not very low, and the fasting insulin was very high, and fasting C-peptide was or mediocre, where the normal weight had almost 280 fasting insulins. The final feature, the seventh feature, has the beta cell status with regards to autoimmune damage, and I have already told the autoimmune markers are not there, and taking all this GAD antibodies, the islet cell antibodies, the tyrosine phosphate, and then these markers of type 1 diabetes were negative in this class of patients. So this shows the auto antibody status, and then this is the summary of that. So to conclude, ladies and gentlemen, lack of markers of autoimmune destruction and adequate beta cell reserve in the HOMA beta and the insulin resistance in the HOMA IR despite gross lack of obesity indicate that low body weight lean type 2 diabetes are neither a slowly progressive type 1 nor LADA, but are phenotype variant of classical type 2 diabetes mellitus. And then in our distinct study, we have got all the features without low HDL, raised triglyceride, BMI below 19, and they are lean with clinical features of malnutrition, low values of homocysteine, HSCRP, and nuclear factor kappa B, and negative guard antibody and islet shell antibody. So peripheral neuropathy was consequence of poor glycemic state and increased susceptibility to infection and endothelial dysfunction as proteinuria dominate the clinical picture. Due to associated infections, coexistent severe hypoglycemia and glucotoxicity persisted, and many initially may not respond to OHA, but subsequently many were controlled with oral drugs. The insulin resistance observed in type 2 diabetes lean is due to anthropometric parameter, the central obesity, and an waist-step ratio, but could be integral part of their pathogenic mechanism. So to summarize, the malnutrition associated clinical features and the parameters are different than that classically we see in type 1 or type 2. So what has been detected 5 decades back in Odisha, in Cuttack, has a sense, and the type 5 has been taken for that, and there are studies comparing the different phenotype, and we have a contribution from our registry related to that, and in future we'll know more about this diabetes. And in your practice also, you note all those who are having a BMI less than 19 or 18.5, you keep their clinical profile, keep their guard antibody, keep their HOMA IR and HOMA beta, and then see how they are behaving, and then you will know that they are more towards type 2, and maybe you'll get a history of malnutrition related. A significant class have pancreatic diabetes as well. So I do a CT scan of pancreas routinely, because now ultrasound only is not approved to rule out the pancreatic diabetes, the FCPD or pancreatic calculi. So this profile in future will tell us more about type 5. By that time we have to be sure, and remember, India and Africa are the countries which face the brunt. So world looks to us to tell more about this entity. Thank you all for the time.
Yeah.